Okay, so don't look at انت لو مش مهتم ممكن تقفل اصلا الصوت او تحط في السماعات
حط السماعة. لا، مش الدرجات دي، يعني
مش
لازم
الدرجة دي.
تكون فاهم.
Man. Alright, so we have a 24-year-old woman, 39 weeks gestation, who immigrated from Asia, is admitted to full labor and delivery. She's group B. I got this question wrong here. Let me redo it again. She's group A negative, received anti-immune globulin G at 10 weeks gestation due to vaginal bleeding, and again prophylactically at 28 gestation. Okay, so she's A negative. We said that if she's AB, she has no risk. If she's AB, she has no protection. If she's O, she has complete protection, and if she's A, she has partial protection. And she received anti-D at 10 weeks gestation due to vaginal bleeding. Okay, fetal maternal hemorrhage. And again, prophylactically at 28 weeks gestation. The patient received platelet concentrate in childhood for dengue-induced thrombocytopenia. All right. She has uncomplicated vaginal delivery of a girl. Apgar scores were normal. Which of the following would be an indication for the postpartum administration of ROGAM? All right, so when do we give you ROGAM? ROGAM is an immunoglobulin against the fetal antigens, right? The D antigen. She's A negative, so she doesn't have the antigen. So you want to prevent isoimmunization. So an indication: patient having an atypical antibody titer of 1 to 8. This patient is already alloimmunized. This patient is already alloimmunized. Yeah, you don't give her that. This patient's she already has the antibodies, so yeah, if she's like atypical antibody positive, that's done. It's an indication of not giving ROGAM, right? Specific titer of the antibodies has significance in the specific titer of the atypical antibodies have significance in the antepartum period, where in a critical level of the titer is an indication of further assessment of fetal anemia. That's why he said, didn't he, in the lecture? He said, okay, all right. Patient's husband being blood group O positive. That's not an indication, because yeah, I mean that increases the risk of her being alloimmunized, or the baby having a positive or the antigen. Right. Once the typical antibody is no. So if the infant is group A positive, yeah, you give her, right. If the infant is just group A positive, so just he has the antibody. All right. 20-year-old woman. Irregular vaginal bleeding. Okay, what's the question? Which of the following is the best initial treatment? Which of the following is the best initial treatment for this patient? All right, they want the treatment here. Okay, so we have some contraceptive methods here. She's 20, menarche at 8, menarche at 10, menses every 30 days, 6 days. Okay, normal, regular. Okay, so the bleeding is regular. However, for the past 6 months, bleeding has occurred every 2 to 7 weeks and consists of 3 to 9 days of moderate bleeding. So that's regular bleeding. Okay, we can give her that because of the aura, migraine with the aura. She does not smoke or use illicit drugs, drinks beer. Her BMI is 29. Okay. Speculum is a scant amount of dark blood in the vaginal wall, no active bleeding.
Oh,
So
okay.
if no active bleeding, I don't think we give her that. Alright. A bimanual examination shows no uterine or adnexal masses.
So that might be a barrier too. So what do you think about that? Do you think it's a part of the process to improve transportation?
Okay.
Is to do
Progesterone pills.
In a cleaner way.
What is the cause? Probably the cause is anovulation, since she's 20 years old. That's the most common cause in 20-year-old women with irregular vaginal bleeding. So anovulation. Yeah, anovulation. How do you treat anovulation? Estrogen? No, I don't think so. Probably D or B. I'm not sure. The pot medroxyprogesterone acetate. Alright, so the best treatment here that I think is combined oral contraceptives, but D is like secondary to that. I think so. Wow, okay, I got it right. Alright, okay, so yeah, I was right. I think so. Let's see why the other options are wrong. So I think she's 20 years old. 20-year-old. Menses that is 3 to 9 days of bleeding every 7 weeks. Alright, that's what she has. She has moderate uterine bleeding, defined as bleeding occurring as for 7 days, or frequent menses every 1 to 3 weeks, and hemoglobin more than or equal to 10. She has 11 here. Okay, so the uterine bleeding, we say moderate, mild, whatever, depending on the hemoglobin, depending on how long, I guess, she's bleeding for, and the menses. Alright, what's the next step? For abnormal uterine bleeding. The first line treatment for abnormal uterine bleeding include COPs. For the management of anovulatory bleeding, and the most common cause in 20-year-olds, I guess, is yeah. So let's see the educational objective real quick. Okay, abnormal uterine bleeding is defined as a menstrual bleeding of abnormal volume, duration. Hey Yusuf, what's up, bro? Bleeding. I listen to advice and want to do questions on stream. I will not watch videos on stream. Yeah, I saw you. Alright, progestin only therapy is an alternative in those with contraindication to estrogen is evident in this patient with migraine with aura. Other contraindications: lupus. Wow, lupus is contraindication to yeah, this will not work because this will increase the bleeding. We're trying to because she has I guess she has I was wrong about eliminating C, because she has aura. What is tranexamic acid? What the hell is that? Tranexamic acid. Yeah, anti-TPA, I guess. Anti-TPA. depot. All right, so DMPA and intravenous estrogen are additional options who need contraception or are unable to take pills effectively. Is a maintenance therapy considered for long-term management, whereas IV estrogen is recommended for severe bleeding leading to significant anemia or hemodynamic instability. Hey Omar, what's up, bro? All right. Yeah. Okay, so that's how I actually learned the contraception method, using getting all the questions wrong. So the first step is oral contraceptive pills. That is the best. If she has any contraindication to estrogen, we give her progestin only pills. So the pills are like first line. If she cannot keep up with the pills, I had an issue with Instagram, that's why I didn't accept your request at first. It's fine, bro. Thanks for accepting it. So if she has any, she cannot keep up with the pills, now we'll look at long-active reversible contraception methods. So LARCs, right? One example is depot medroxyprogesterone. Yeah, so DMPA. Alright, IV conjugated estrogen is recommended for severe anovulatory bleeding, significant anemia, or hemodynamic instability. So her blood pressure is not that low. She's 108. If she's hypertensive, probably would give her IV estrogen. I didn't know that, actually. So IV estrogen is given to... Alright, let me write that down. Okay, guys, so I was wrong about not taking notes, I guess. So you either take notes or do Anki, or do a lot of questions. But the problem is, I see contraceptive questions, you know, here and there. So let's try OCPs, progestin pills. If not, LARCs. Yeah, how to take notes, teach me. How to take notes. Right, so you gotta make sure that you understand, your brain goes well first. You understand the material first before even thinking about putting notes into review, right? So your notes are your conclusions, you know? Notes equal conclusion. Your conclusion, the distilled conclusion you put it. So that's why everybody's notes are different, or everybody's notes is different. Yeah, that's why. So you put your conclusion, the last step of your thought process, you put it in writing, and in a way that you understand, right? That's why notes are personal, right? Okay, I'll take some notes here. So I just learned that. All right, so let's put this contraception, right? So I see contraception or bleeding. Good, so I don't write them while studying is better. No, yeah, exactly. So what you write, if you need to write, sometimes writing while studying is better, or is good, when you don't have your thoughts arranged properly, right? So you want to put down your thoughts in notebook. I'll answer your question, I know that. Yo, why pregnancy is contraindicated for women? I'll tell you. I think you know, right? Or are you pimming me? All right, let me answer your question, and then why pregnancy is contraindicated 1 month after MMR vaccine. Because pregnancy is in an immunocompromised state, so you can get measles, mumps, or rubella. You know the same reason why Accutane, or the same reason why Accutane, which is the drug that is used to treat what is it, acne, that causes severe injuries to the baby. That's why also MMR is contraindicated in pregnancy, or you should avoid in pregnancy, because you can infect the fetus with rubella or whatever. Yeah, retinoids, exactly. Its trade name is Accutane. Like I hear a lot of people say Accutane, isotretinoin. Okay. All right. So IV estrogen is. So actually, I don't need to take these notes here because I saw a lot of questions about contraception and I already got the conclusions I needed. You know, I don't need to put it into writing. So I'll just move on. All right. I eliminated this properly. I didn't know why I eliminated this, but I felt like it doesn't work. So the way this is wrong is the patient has more than 10 hemoglobin and it's not life-threatening or hemodynamic instability, AUB, right? Estrogen is for life-threatening, I guess, bleeding, right? Tranexamic acid it could be used, but if I don't want any hormonal options, let's say there is a OB-GYN woman who doesn't want to take hormones for bleeding, right? Let's say this is an OB-GYN woman, OB-GYN doctor, and she hates hormones for whatever reason. Now we give her tranexamic acid. Okay, it's hemostatic. You're basically decreasing the risk of her bleeding out. Oh my god. Okay, the answer to this question for me. Let's see. Which of the following is an important next step? A pregnant woman, 8 weeks. Fever and back pain for 3 days. She takes daily prenatal vitamin. Right-sided costovertebral tenderness. Initiating intravenous impact therapy. Nasal pruritus and tingling of her lips and tongues. Yeah, I remember this question. So this is adverse. This is what is it? Adverse reaction from the empiric therapy. The way to answer this is that she has from KSA company. I don't know. Maybe she has pyelonephritis, I guess. And where's the antibiotic she took? Yeah, is that pyelonephritis or what? What is the treatment of pyelonephritis in pregnancy? I think it's the same treatment as asymptomatic bacteria, right? Nitrofurantoin. Nephritis in pregnancy. So, for example, I forgot this information here. Let me check my cards. I think I have it in here. Look, I don't even do my cards. Nephritis. Alright, I know the symptomatic ones. Alright, look, the answer is estrogen and whatever. Let me see why. Fever, chills. Parenteral beta-lactam antibiotic. Okay, for example, this question I got wrong, right? I don't see it here. Let's see strategy. They have a nice. I like Kaplan this part. All right. Okay, 27. She's pregnant. Fever, pyonephritis. Blah 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 blah. Beta-lactam allergy and acute septic pyonephritis. Oh, she has sepsis. Oh damn, the blood pressure is low. She's starting to have sepsis. Parenteral broad spectrum beta-lactam antibiotic. Huh. Yeah, aztreonam is basically not a beta-lactam, but it does the same job. Clinically available monobactam that used stable in penicillin allergy due to evidence of meropenem. Meropenem is a carbapenem. I think. Is it also beta-lactam? Not sure. See why C is wrong. Oh, carbapenems is a beta-lactam. Okay. Damn. Carbapenems are beta-lactam. Alright. The most common cause of sepsis during pregnancy is acute pyonephritis. Wow, I didn't know that. The first line treatment for asymptomatic bacteria. Yeah, I know this. دكاترتنا الطرش. Is that a compliment or refractory pyelo? Oh, here it is. Damn. Here it is. It's actually high yield. Cheesy Dorian. How do you manage pyonephritis in pregnancy? Ceftriaxone. If refractory, ultrasound to rule abscess. Refractory pyelo, you treat 14 days with antibiotics and use ultrasound to check for abscess. You do not use CT in this case because of radiation and she's pregnant. Alright, I'll put that to work. How do you manage pyonephritis in pregnancy? Alright, I think I'll just gotta do my cards again. There's no escape, I guess. Alright, IV ceftriaxone is a treatment. Do you add a card when you think you'll forget it, when you think it's important? If I'm sure I'm not gonna forget it, I'm not gonna activate it. So it's both. I think it's important and I'm gonna forget it. A lot of things are important, you know. But the things that you're gonna forget, just put it into cards. Alright, let's move on. Which of the following is the best next step in management? A woman involuntary urine loss when she picks up her children, laughs, or sneezes. They lost her second delivery and she avoids leaving the house because of it. Symptoms have not responded to 3 months of pelvic. Alright, the patient uses insulin. Pelvic examination and your analysis are normal. Alright, she has stress incontinence. Yeah, she has stress incontinence. And she tried pelvic floor exercises, but it didn't work. Imipramine is imipramine. Imipramine is tricyclic antidepressant. Okay. Avoiding diarrhea and timed voids. Intermittent self-catheterization. No. Pessary, intermittent self-catheterization. I think that's an overflow continence. LC, BLC. Pessary, please. I want to eliminate all the questions because this is how you study. Vaginal estrogen supplementation. This is if you have, she is an old woman and she has menopause, and she has the vaginal wall is weak, so it doesn't help the continence. Pessary placement. Let's leave this. Maybe it works. Antimuscarinic, that will work too. Antimuscarinic medication. Avoiding diarrhea and time voids. I think this is, yeah, I think this is for, what is it? Urgent incontinence. Urgency. Yeah, this is for urgency. Let's go with A. I think D is old. Yeah, it's D. I was right about elimination though. I'm happy, so let's see why B is wrong. It's urgency, so indicated for the treat. Oh, actually A is also for urgency incontinence. Okay, so I was right about eliminating B. C is intermittent overflow. I was right about C. E. is indicated in stress urinary incontinence, which is thought to be vaginal atrophy, premenopausal. Okay, I was right about elimination, but I wasn't right about getting the question right. I think D is old-fashioned. I don't know. Turned out to be right, man. Alright, so... Okay. So what we get from this question is that if a woman has stress incontinence, she's premenopausal, 34-year-old, and she has stress incontinence. She tried pelvic floor exercise, but it didn't work. I guess because also she's taking imipramine. Imipramine is antimuscarinic, by the way. Imipramine is antimuscarinic. Right, let's see how pessary look like. Pessaries. I kind of know how it looks like. Pessary. Alright, it supports the vaginal wall here. Yeah, okay, as if it pushes on the vaginal wall or the bladder here, so works for stress. Alright, I marked this question, so that means I got it wrong before. Which of the following is the most appropriate next step in management? Painful contractions. Trend, preterm abortion. Okay, I'm actually highlighting randomly. Let me just highlight the important stuff. So the practice is the way you play, right? So let's just try and do as if we were doing it in the exam. All right, so she has recurrent preterm labor. I think we gotta stop the contractions. She's preterm. Magnesium sulfate is given less than 32 weeks, sorry. Penicillin, what do you give penicillin? Oh, okay. You might want to give penicillin if she's preterm. But she doesn't have nifedipine, I think. D, no medication. She's 34 weeks. 34 weeks gestation, she's not ready. And the baby is fine, the fetal heart rate has baseline of 150 and is reactive. No medication. I don't think it's D. Alright, this is wrong for a reason. Betamethasone. I mean, she already got a course already. No medication. I don't believe it's D, even though I don't know. Wow, I actually imagine I solved this question before, and probably I got it wrong. I don't even remember it. I don't remember anything about it. So weird. Penicillin. Penicillin if she has a risk. All right, so here this preterm is high risk for streptococcus, group B streptococcus, right? But she doesn't have any other reason why would we give penicillin. Like but actually, look, I have in my notes here. Look, I have in my notes that women who had no prenatal care and have risk factors, if they are preterm, we'll give them penicillin, but no prenatal care. So she takes prenatal, no chronic. I think it's C. No way, bro. Really? Okay, let's see. 24-year-old, several hours of painful contractions. Don't listen to me, I just used my memory from 2 years ago. It's fine, bro. She was hospitalized 28. Come on, man. Come on, why is C wrong? Why is C wrong? Isn't that a very stupid question? Isn't that a very stupid question? Tocolytic agent not administered after 33 weeks gestation. Why penicillin? Because, yeah, for prophylaxis, obviously. Because she's preterm. I'm actually so annoyed. How is she ready, bro? How is she ready right now? 33. Why do we even try to make her give birth? I don't understand. This patient is in labor at 34 weeks and GPS prophylaxis is indicated. The first line agent. Yeah, I told you guys. I think my notes are wrong, I guess. With no prenatal care. I mean, she takes daily. They didn't even tell us that she didn't have prenatal care or she had prenatal care. We don't know. Like, we know, but because we give a urine culture at first trimester. We give the patient urine culture at first trimester. Yeah, here it is. Urine culture first trimester, and then vaginal culture 36 weeks. So why don't we induce labor? Alright, let me send this question to my friend. I don't understand. This is why didn't we deliver the baby? Okay, I'll send it to Yusuf Thomas. Sorry guys, I have to see my friends. My friend is making fun of my hairline. Holy shit. Okay, sorry guys, just a break here. Mish. I'm gonna mark this question again because I don't know what the hell's going on. Alright, so obviously nifedipine is wrong because she's less than 33 weeks. But this piece of information, I don't think I'll even know about it. Do I have to memorize that? Damn. Okay. When potential complications associated with the inhibition of preterm labor outweighs its benefits. Okay, wait. I said 34 is like the 7th month, and I remember it's okay to give birth at this time. Not the 8th. Really? Is it okay? Right, I'll just take this because I could have gotten this right if I eliminated C. I'll put it in my notes here. So I guess, oops, I guess you can just, nifedipine is a tocolytic agent that is generally not administered. I don't like the highlight. Not administered after 33, 6, 7 weeks gestation. What is 6 and 7? 6/7. Alright, whatever, man. Why don't you give betamethasone? Betamethasone is indicated in the late prenatal period, 34 to 36 were within the 7 days who have not previously received it during the current pregnancy. This patient was administered at 32 weeks and therefore is not a candidate. Okay, because she took betamethasone before, so she's fine now. She doesn't need betamethasone again. Okay. Which of the following is the most appropriate contraception? Alright, a contraception question. 31 year-old woman. She's worried she might be pregnant. She had intercourse one day with her boyfriend and the condom broke. Her last menstrual period 2 weeks ago. Monogamous, whatever. Used exclusively. Interested in a second form of contraception. I think my friend answered. No, he didn't. Okay. Which of the following is appropriate contraception? Alright, let's see. She's interested in a second form of contraception. Why? Oh, because the condom broke. Alright. So she wants something safer. She has migraines, so we cannot give her combined oral contraceptive. We cannot give her... I don't think we can give her this one, vaginal ring, because of also hormone, because of estrogen. So copper. So we looking for something long acting and safe, like intrauterine device. Etonogestrel contraceptive implant. Levonorgestrel containing B. Why not E? I don't know. It gotta be IUD, but contraceptive implant. I don't know why is it not C though. I don't know why it's not C. I say B because she will use it for a long time. I mean, this is also ID, bro. Etonogestrel implant. Emergency con. I swear I knew that. But. Oh, 1 day ago. 1 day ago. Oh no, bro. Yeah, I remember this question. Alright, whatever. I'm not gonna be upset because upsetting myself is just gonna make things worse. And what I would just what is the word? De-encourage me. So I'm not gonna care. We're just learning here. Alright, so D is fine, I guess. Estrogen. Yeah, so D is hormonal. C, A is wrong because she's, oh, whatever. All right. Mistakes makes you stronger, brother. Yeah, I need that, bro. Come on, thanks. A 62-year-old newly parents woman comes to the physician for routine health maintenance examinations. You know why? Like, you're right. So mistakes make you stronger. But I got this mistake before, and I shouldn't get it again. And I got this mistake before, and I shouldn't get it again. I don't know about this. I think I got it wrong before. So all these, I think, are my incorrects. Right? I still got them wrong too. So that is not good. That is not well. You should get the mistake once. You shouldn't do it twice. So, or it's fine. I just forget, I guess. It's okay, next time you'll remember that. Yeah, I hope so. Better than exam. True. That's true. Better than an exam. Okay. Okay. It's fine. It's fine. Administration of which oral medic... Okay, I'm gonna focus now. I'm gonna do this mistake again. So, administration of which of the following oral medications is indicated in this patient? This patient is a... Alright, nulliparous woman. Just a routine exam. One second, guys. I'll close the door. I can't focus. This is an aromatase inhibitor, right? We can give her that because she has deep vein thrombosis. Or can we? I mean, she has once. She has deep vein thrombosis once. She's old. She probably has osteoporosis. So, okay. Leprolide, no. Tamoxifen. It's going to increase the risk for endometrial carcinoma. D. We can't cause she have risk factor. Yeah, I think it's D. Let's see. All right. 1 second here. What is anastrozole? Oh, oh, damn. It decreases estrogen. I thought it increases estrogen. Oh, yeah, it makes sense. It decreases estrogen. Why is D wrong, though? D is good. D is fine. What? Oh, there's still SERMs. There's still estrogen modulators. There's still estrogen modulators. It's good for her postmenopausal and prevent cancer. Yeah, but she has a risk of, she had deep vein thrombosis. So she's at risk for other DVTs or like thromboembolism. Yeah, I eliminated A because I thought it decreases estrogen. It increases estrogen. Yeah, and she didn't even complain of that. So we're trying to give her chemoprophylaxis against breast cancer. All right, that's fine. All right, so so here is the note, right? Here's the note that I'm gonna review here. SERMs chemoprophylaxis breast cancer if thrombosis risk high and anastrozole decreases estrogen. So when I read that note, I'll just remember the information. I know it's kind of hard for you to to get advice from people who make mistakes, but I got a good score on step 1, so hopefully for step 2 inshallah. Yeah, thank you. Results from which additional test would be appropriate prior to initiating antiretroviral therapy in this patient? All right. All right, so I mean, she's still 9 weeks. Yeah, I remember that question. I like the way you think. I want to rearrange my way of thinking. I just say the way I learn again. I appreciate you, bro. Thank you. All right. No other test results are needed because she is HIV positive. She's 9 weeks intrauterine pregnancy. She's not gonna deliver anytime soon. So we gotta treat the HIV no matter what. If she's gonna deliver though, you're gonna do the viral load test. So you're gonna do a viral load test to confirm the viral suppression has been achieved. Okay. All right, finally a question. Next step in management. All right, so you want to confirm she has syphilis. This is RPR. It's reactive with 1/4 titer. So I understood something about this. So if you have antibodies in the blood, the test you do is that you start diluting the blood. So 1/4 titer, that means you diluted it 2 times, and you had to dilute it 2 times in order to be negative. So it's slightly positive, right? So the confirmatory test is FTR. This is a screening test. I'm not gonna do this mistake again. This is a screening test, dark field microscopy. No indication for that anymore. Maybe study. Yeah. Why would you do A? The patient is asymptomatic and has no lesion. All right. Desensitization followed by intramuscular penicillin. Desensitization followed by intramuscular. If she has confirmed, yeah. Yeah, if she has confirmed syphilis, we'll do that. Oral doxycycline if she has anaphylaxis to penicillin. Yeah. I'm happy when I remember these things. All right, so I'll just feel good about removing these answer choices. I'm not gonna feel so bad. Maybe I haven't studied this. I didn't really focus on this part here. This question, I forgot what anastrozole does. So these are just dumb mistakes. I think by solving a lot of questions, I'll just improve on my own. All right, so so that you guys know what I'm doing. I'm doing my incorrects in OB-GYN. After doing my incorrects, I'll start doing random blocks every day because I have my AMBOSS self-assessment on April 28th. I'll do my AMBOSS self-assessment in the library. I'm not gonna do a live stream because I want to focus on it. I'll do it in the library and I'll show you guys the result. So I'll tell you how it works till now. I want to know my baseline. What is the score? What is my score at that time? Which of the following is the next step in management? 27-year-old woman, gravida 2, para 0, aborted 1. She's alright. Alright, so she aborted 1 time. Alright. Several hours of lower abdominal pain, vaginal bleeding. Okay, let's see. Serum HCG is 3,872. Transvaginal ultrasound shows an empty uterus, normal fallopian tube, and ovaries bilaterally. Scan fluid in the... Alright, I'm not going to do this mistake again. I picked the last time, I think I remember, I picked C, but she's stable. Her blood pressure is normal. So we're not going to do a laparoscopy, right? Her HCG is 33,872. We're going to do this. And administer intramuscular methotrexate. I think the reason why is because she could have a normal pregnancy, but it's very small to tell. Her last menstrual period was 7 weeks ago. But I mean, I think you could still see. I think you could still see a sac at that time. Let's see. So bimanual pelvic examination shows a closed cervix, normal-sized, non-tender uterus, and an axil mass. All right. So she has a scant free fluid in the posterior cul-de-sac. That tells us there is ectopic pregnancy. I think because of rupture, or why? Why is there scant free fluid? So why is it ruptured and not yet she's stable? I don't understand. All right, I just remember the answer. That question is not. All right, let's see. Okay, so C. What is happening? Next step in management. All right. She is 7 weeks gestation, lower abdominal pain, closed cervix, elevated empty uterus, complete abortion, and ectopic pregnancy. All right, that's nice to understand. complete abortion, and ectopic pregnancy. Yeah. You know what's annoying about this QBank is that you cannot put this question into a folder. So I want to put a folder in which, you know, these questions I have no idea about. I need to review them again. But there's no such thing. I think there is New World. I'm not sure. Oh, passage of clots. Yeah. It's kind of weird, kind of a weird question, because complete abortion means the fetus is completely expelled. Complete abortion, the fetus is expelled from the uterus. So the cervix should be closed, not opened. Oh wow, wait. Wow, the cervix is closed. Oh. Yeah. Complete abortion is the cervix goes back to its normal size because it's already done. The pregnancy is over. So the cervix goes back to its original size. So this is closed not because of pregnancy, because it's over. The cervix gotta go back to its origin. So that's the difference in complete and incomplete. Incomplete means the pregnancy is still going on, or still you're still getting rid of the baby. So the cervix will be open. Yeah, makes sense. Okay. Yeah, so empty uterus, normal fallopian tube. So we're looking for complete abortion or ectopic pregnancy. Have this tissue to evaluate. Therefore, patients whose presentation is consistent with complete abortion. All right. So basically, we gotta do suction curettage. There is nothing to be suctioned. There's nothing to be suctioned here. What the fuck? Vaginal, mesoprostol, and suction curettage are indicated for missed abortion or incomplete abortion. Yeah, missed abortion or incomplete abortion. Here's incomplete. Here's missed. Incomplete, missed. Inevitable, I think you're just observation. That's the next step, observation. You'll see, you know, it's gonna, or threatened. No. Threatened is inevitable. I think also Suction and cure diet. Is the abortion? All right. Okay. Good. All right. Let's read the question again quickly because I got this question wrong twice. The main complaint here is lower abdominal pain and vaginal bleeding with the passage of clots when she's pregnant, 7 weeks gestation, right? So we want to check the pregnancy, right? So if she has bleeding and abdominal pain, we want to see is the pregnancy fine? How is it? So we did a transvaginal ultrasound to check the uterus, empty uterus, normal fallopian tube, and ovaries bilaterally, and scant fluid. Okay, so that gives us only two options, either complete abortion or ectopic pregnancy, right? And because serum HCG is positive, so we do this in order to check, oh, this ectopic pregnancy or this complete abortion. Which of the following is the most appropriate next? Okay, streptococcus. I'm not going to get this question wrong. Which of the following is the most appropriate treatment for this patient? All right. She's pregnant. 37 weeks. Painful contraction, blah, blah, blah. She has not received prenatal care. See this, guys? She's taking prenatal vitamins, but she has not received prenatal care. The question that I got wrong here was that, yeah, she takes daily prenatal vitamin, but they didn't say, yeah, sure, so possibly she could have easily missed her prenatal care. That's why we cannot say for sure, because she's taking daily prenatal vitamin, if she's doing it or not. Okay, that's fine. So has not received prenatal care. Medical history is unremarkable. She takes daily prenatal vitamin. History, anaphylactic reaction to penicillin. All right. 4 centimeter dilated, 80% phased, 0 station, prenatal culture, 10,000 colony forming units, for which cultures and sensitivities were not performed. All right, so okay. So we agree that she's gonna take penicillin for the first reason. Okay, first of all, she didn't get prenatal care, but she got a urine culture, which is weird. That's weird, actually. Whatever, man. I don't think this Q-Bank is high quality. They make a lot of mistakes. Alright, so 10,000 colony forming units for group B strep. And she has anaphylactic reaction to penicillin. Right? So we gotta treat, first of all, she's at labor, so we gotta give her something for the strep B. Okay, we gotta give her something. We cannot do no treatment here. Okay. What is this? Wait. Yeah, I remember that. I read it in Kaplan. They said clindamycin or vancomycin. They said both, bro, and they have it here in the answer choices. Clindamycin or vancomycin? Okay, what the hell am I gonna give now? Okay, there gotta be a hint in the question saying something about either. I don't know, I'm just gonna be... Oh my god, bro. Okay, I'll show you guys. This is unbelievable. This is unbelievable. I show you, actually, that they have both answers in the question. Wait, not first aid. Let me show you the Kaplan garbage here. It's annoying, actually. So here it is, right? Look at this. Here's the Kaplan stuff. Okay, the purpose is to decrease intrapartum antibiotic prophylaxis. IV penicillin. If the patient is penicillin allergic, use clindamycin or vancomycin. And clindamycin is before vancomycin, bro. And they still like. Wait. B and C. Clindamycin and erythromycin are indicated for intrapartum neonatal GBS in patients who are GBS colonized, penicillin allergic, and whose sensitivities show susceptibility to either agent. Okay, isn't that a dumb question? Like, I do have a right to get this question, to just delete it, bro, right? I mean, that's too much guidelines. That's too much guidelines, actually. Let me write. Alright, let me write this in my notes here. Let's not be egotistic and just learn. Clindamycin, if penicillin allergic, susceptibility known. Vanco, susceptibility unknown. What? Susceptibility. Okay, susceptibility unknown. Right, so I'll just make this red here. Unknown and susceptibility known here. We know, so we can use clindamycin. It's so funny because I get the questions wrong in different ways. You know, sometimes I don't know this fact, so I pick, for example, this, and then next time I'll make another mistake and a new answer choice. All right. Which of the following tests is most likely to confirm the patient's diagnosis? Which of the following tests is most likely to confirm this patient's diagnosis? 18-year-old itchiness in the vulvar region, foul smelling vaginal discharge, postcoital spotting. I mean, that's Ferrate green discharge. Remember, guys? Trichomonas. Wait. Yeah, trident. So trident is strawberry and trident is green. So what do? So in order to confirm the patient diagnosis, I think we just gotta do a wet mount. Potassium hydroxide. Or NAT. I think we can do NAT too, right? The amine test is for the fishy odor. Yeah, potassium hydroxide is for Canada. Oh my god, bro. Potassium hydroxide is for Canada. Yeah, I knew it's NAD, but this is easier to do, you know. We usually diagnose it with a wet mount, I swear to God. We diagnose it with the wet mounts. Yeah, see, saline, yeah. Sorry, saline wet mount. Not a wet mount, sorry. NAD. Which of the following is the most appropriate Yeah, actually, I'm making the same mistakes. I did this mistake before, and I did it again. No, this... Which of the following is the most appropriate next step in management of this patient? No trauma. Oh wait, she has left. Yeah, this is a screwed up question. I think I remember why I got this wrong before. I think I picked mammography and ultrasound, and then the answer was C, because if she has a papilloma, it will not show anything, and then you have to do an FNA again. Yeah, I think it's C. Yeah, C initial. Oh, okay, I mixed that. It was a second question after it. Initial mark imaging marking. Breast MRI, I think. Right, initial imaging, including mammogram and ultrasound, is completed, and the findings are unremarkable. Initial imaging, mammogram, and ultrasound is completed, and the findings are unremarkable. Yeah, I think we do breast MRI. Large needle core biopsy is kind of weird. Weird answer. Ooh, okay. So we don't just do the fine needle aspiration blindly, you know? We don't do that. We don't see anything. We gotta do this first to see where the mass is, and then if it's not there, we will still have to look for something to do fine needle biopsy on, which is we do an MRI. Okay. Which of the following is the most likely diagnosis? All right, I like these questions. A little bit high AST/ALT. Glucose is normal. Creatinine is normal. Platelets a bit low. Hemoglobin, normal for a pregnant woman. It's 36 weeks. She has hypertension. A little bit of edema. All right, so So she doesn't have a right upper quadrant pain, so it's not help. That's for the first one. And the second one is, I think the platelets have to be lower than 90,000. I got this question. Without severe features or with severe features, I don't remember. She doesn't. Yeah, without severe features. Okay, I gave up, guys. I gotta do cards. There's no way. I'm trying to do, trying to remember the information without cards, but the questions, there is no questions that test your knowledge about all this stuff. It makes sure that you understand the material or whatever. Like where? Here is a random question, very, very advanced. It's talking about very high yield topics, right? And they assume that you know all of them. They assume that you know all of them, and they don't test you about it, and they depend on you eliminating all of them by your own. Like there's no questions. This is very advanced. All right, so let's eliminate one by one. Acute fatty liver of pregnancy. Acute fatty liver of pregnancy. Okay, let's remember the pathophysiology. So the fat metabolism is screwed up, so the fat accumulates in the liver, leading to pain, yeah, because it will right upper quadrant pain, and it will lead to, because of the Gleason's capsule there, it's stretched. And what else? Yeah, liver functions will be screwed up, so there will be no proteinuria, I think. The kidneys will be, or there will be kidney injury, I don't remember. Okay, let me check. Hypertension, proteinuria, and transaminases. However, there's typically nausea, vomiting, abdominal pain, hypoglycemia. Yeah. Okay. I'm gonna do all my cards. I don't care. I wake up every day. I train. I go outside in the weather. I do some cardio. So I'll do my cards when I'm doing cardio. Acute fatty liver of pregnancy. Is managed with immediate delivery, progressive nausea, vomiting, right upper quadrant pain, fulminant liver failure. Alright. Profound hypoglycemia because the liver cannot make glucose. Aminotransferases 2 to 3 normal. Bilirubin, thrombocytopenia. Yeah, I have in my head. I had in my head that bilirubin is high, but I don't. Is that cholestasis or what? They didn't have bilirubin here. I think because of cholestasis, the bilirubin is high. Thrombocytopenia because yeah. So she has TP. Okay, close that. Delivery. Alright. Intrahepatic cholestasis pregnancy. This question got me. I got this question before, but she didn't have any other symptoms other than stasis. Intrahepatic cholestasis of pregnancy. Yeah, she has itchiness and jaundice, and that's it. Yeah, so here it is. Intrahepatic cholestasis of pregnancy. Intense pruritus, that's the most important thing. And diagnosis of exclusion. Alright, let me activate this one. Has increased bile acids and itchiness. Increased acute fatty liver of pregnancy, acute cholecystitis, acute fatty liver pain. Causes fulminant hepatitis. Hypoglycemia. Oh god, fulminant hepatitis. Alright, let me activate this one. Yeah, I remember this one. I'm not gonna activate it. Acute fatty liver disease of pregnancy. I have in my mind that the treatment is delivery, but I have to activate it. Acute fatty liver of pregnancy can DIC. I know this. I kind of know this one. Acute fatty liver of pregnancy causes severe hypoglycemia. Yeah, I know that, but I didn't recall it. See the difference? I knew this, but I couldn't recall it. So recalling it is an important part of solving the questions, right? So I just remembered. Oh, she doesn't have abdominal pain, so it's probably not A. But I do remember the other symptoms that excludes why it's not A. So recalling is important. Just remembering it is not enough. Okay, I already have this one. Acute fatty liver of pregnancy develops in women with multiple gestations. Alright. Acute fatty liver in pregnancy develops in third trimester. Okay, I didn't know this one. Third trimester. Why? Third trimester? I don't know. Which has worse symptoms? Acute fatty liver, intrahepatic cholestasis. Acute fatty liver has worse symptoms. That is too much for a card. I'm not gonna activate that. Patients with pruritus. Okay. Alright, so I know why it's not A then. Gestational hypertension. She has no chronic medical problems. Vastly elevated since her last visit. Gestational hypertension will not present with all these other symptoms. It's not B. HELP syndrome, I think it's got to be less than 100,000. And hemolysis, there's no hemolysis. Okay. Preeclampsia with severe features. Can present 20 weeks. Yeah, this is high yield as hell. This is high yields a lot. Preeclampsia with severe features. My friend actually memorized it so much. I asked Yusuf Tanas, what are the severe features? He told me all of them at once, so I gotta know this. Yeah, here are the severe features. SBP more than or equal 160, DBP more than or equal 110, thrombocytopenia, increased creatinine here was normal, transaminases are high, the blood pressure here was 150, so it's gotta be 160 or more. DPP more than 110, it was with 90 here, 2 times more than or equal 4 hours apart. Thrombocytopenia, increased creatinine, pulmonary edema. That makes sense because the vasculature in the lungs will be affected. The alveolar blood vessels will be, destroyed. Visual or cerebral symptoms. So, yeah, like headache, or she didn't have a headache, did she? No headache, no visual symptoms, blurring or whatever. No, nothing. All right, so let's see the treatment here. With severe features, delivery at more than or equal 34. Without severe feature, delivery at more than or equal 37 weeks. So we can wait for her, I guess, but at more than or equal, wait, no. Without. Oh, so I think so. I think if she's more than or equal to 34 weeks and she has no severe symptoms, we can wait till term. But if she had severe features, we have to deliver maximum 34 weeks. Let's see. D. Okay, I'll make this card. I'll activate it. What is it like? Adolescent girl, 15 weeks gestation with preeclampsia, hydatidiform mole. Okay, that's very random. I'm not gonna activate that. Anything that I didn't get a question on, I'm not gonna activate. Preeclampsia without severe features is managed with delivery at more than or equal 37 weeks. Okay. All right. So not immediate delivery. So acute fatty liver pregnancy, we immediately deliver the baby. Less than that, you don't. Okay, if the patient is at least 34 weeks. Okay. Expectant. Yeah, 160 over 110. All right. Which of the following is the most appropriate pharmacotherapy for this patient? Do you watch Jujutsu Kaisen? What is that? Anime? No. I never watched anime. I think the only one I saw is Hunter X. Hunter X. When I was young, but I didn't. Yeah, I loved Hunter X, man. This guy, the Joker, I don't know what his name is. He was very like attractive to me for some reason. I liked his personality. Yeah. It was, kind of scary. What about Invincible? Invincible. No. Do you recommend watching it? It looks nice. It looks very nice. Invincible. Okay, maybe I'll watch it. Man, Invincible is so good. I mean, yeah, it looks so good. It looks very nice. But actually, I'm into video games more, because video games you can do stuff. Watching stuff is very passive. I hate doing passive, even like in studying. Passive studying, passive watching. I don't. It's comics, and Jujutsu is better. All right. I might give it a try. I'll let you know if I did. Maybe you play later. What do you play? Do you play LOL? League of Legends? I actually just uninstalled it because I played a lot of games yesterday. So. Oh damn, you play LOL? This is an addiction, bro. I'm addicted to that shit. I made a video about quitting League of Legends, and I quit League of Legends for about 1 year. Completely. No cravings, no nothing. I didn't have any cravings for League. And then my friend just asked me, come on man, one game. One game. And my life net was never the same again. I got Diamond and I left. Really? I get what, Diamond 1 or what, Diamond what, 4? Diamond 4? Good for you, bro. Can boost me actually. What do you play? Do you play support? Or? Diamond 1. Oh my god. You're a beast. Okay, have you thought about this? Have you thought about tutoring people to play LOL? It's a very nice side hustle. I thought about it. You can make ads or something on Facebook, and I bet you'll get a lot of students. I do it with my friends. No, you can make it a side hustle, like money, and you can make a lot of money of that. So. Bro, I would pay you to tutor me. I will see what I can do. Yeah. Which of the following is the most appropriate form of therapy? Okay, 51-year-old woman. Hot flashes. What is your rank on your role? I play ADC, and the maximum I got is Emerald 4. And then now I'm like silver. Shit. I don't really play anymore. I just play with my friends. But when I like wanted to rank up and stuff, the maximum I got is Emerald 4. OB. Here's my account. I don't know how to see like the maximum rank I got. بجد مبروك. You try to fix your mistakes. Yeah, I mean my only way of rank up was to just watch streamers and just see how they play, and that's it. See your videos. Oh, your games? No. Does it work? Like watching your mistakes? That's a lot of what? Yeah, a lot of work actually. It's a full-time job. Okay, so hear that, right? I'll blow your mind. I thought about make it leaving medicine for a while and just playing League. Imagine how stupid that will be. And then I told myself, okay, this is not gonna work. I'm not challenger, whatever. You know, it's probably not gonna work as a full-time job. And I also liked medicine a little bit, so you can make a lot of money here in being a physician. So I decided to not follow my dreams. Instead, I did that like video game I told you about. Just like the I hope it works. I showed you, right? The logo. I hope this game works one day. I want to be a streamer. Exactly, bro. So I wanted to be a streamer, so that's why I'm streaming. No, that's not the reason actually. I'm just trying to document my journey. But you know what? I feel better now. I'm a streamer. 50%. 50% job done. Yeah. Damn, bro. How do I get my rank here? How do I get my rank? Next time's League streams. Come on, bro. Don't encourage me. see above your name. Yeah, I ended the season Platinum 2, but I reached Platinum 4, then I kept playing random champions. I thought there is a demotion shield, so I went down to Platinum. Can I see like the maximum tier graph? Okay, wait. Sorry, I know I'm supposed to. Bro, sports are really fun, even esports. I would love to do real sports, like real competitive sport. But you know, I got an ACL in both my legs. I used to play judo when I was younger, so I like anything competitive. That's why I made the video about being a competitive champion and stuff. Okay, I don't know where to get that. Forget it. Whatever. You like boxing? Yeah. Yeah, boxing is fun. Okay, let's go back to misery. Which of the following is the most appropriate pharmacotherapy for this patient? Hot flashes. I'll add you on Facebook later. Yeah, bro, of course. You know my Facebook? Just write my name, you'll find me. Now you do the quiz and I go see some MRCS videos. Good luck, bro. Enjoy. See you, bro. Thanks. 51-year-old woman. Hot flashes began 6 months ago. The patient experiences them multiple times daily and is woken by them at night. That's the most. Estrogen is the most efficacious treatment for hot flashes. SSRIs are used to treat hot flashes. Okay, so you give her estrogen. C is if she doesn't have a uterus. If she has a uterus, no. Okay, so estradiol plus progesterone, first line for menopausal hot flashes in patients who have not yet had a hysterectomy. Okay, notes in. When to start? When to start doing what? talking? You mean me? When am I gonna start to talk?
Alright, let's do it without.
I want to talk about resources. Resources of what? Alright, so I think that's choriocarcinoma. Antibiotics? No. Treatment of choriocarcinoma. Bro.
New screen. New everything.
اوه ده خلينا نشجع جيف بيزوس كمان.
بص.
اوه
Let me try that shit.
جامد مبروك.
والله يا عم ده صراحة لذيذ الصراحة.
Okay, that makes sense now. Makes a lot more sense to me. مش بكلمك. اجيب ورقة بس.
عارف ان انت بتتكلم.
لا فهمتش انت بتقول ايه. So first you gotta do the fetal blood test first. Write that down. So RH negative. Indirect Crim's test.
كده حاسس ان هو الايباد مقطوع.
مبروك. Positive. تمام حاضر.
كده احس فعلا انت بتكتب يعني بتكتب فاهم مش بتزحلق. لو كنت بحس انها بتزحلق.
بتزحلق.
مكسوف ليه من الجمهور؟
مش مكسوف ولا حاجة بس
الجمهور ده عارف عادي يعني.
لا احسن ابتديت افهم ولا يعني ابتديت افهم الموضوع.
بسم الله الرحمن.
Administration of anti-immune globulin. There's a lot of tests actually. Atypical antibody. So when do we do atypical antibody? I don't know. Atypical antibody test or Coombs test. When do you do that? When do you do atypical antibody test or Coombs test? The first thing is to perform neonatal blood type to know if the guy has neonatal blood type. So you can give live vaccine. This is done in 28 weeks. Our row immunoglobulin. No vaginal bleeding, no nothing. RH negative. Do you get scratch paper for this exam? That's a good question. I don't think so. I think for step 1, yes, you do get scratch paper. You can request some. I don't know for step 2. You'll be, oh yeah, you can. You do have. They give you like a yellow paper. Wow, even external phallic version you give. UV program. I'm getting some questions right here. Good. Why is that thick endometrial stripe? Do you guys have any idea why septic abortion have thick endometrial stripe? Is that like the retained products of consumption? Is that what it is? Oh, here it is. That's the only reason why it's not C, and the history. Okay, I'll continue doing my incorrects. Just take a break for some time, then stream at night. Okay, I'll see you guys tonight.